Good morning. I don't know how many people we have on, but I'm glad to be here today with you. My name is Tom Clairman. I'm the Director of Outpatient Services here at Sierra Tucson. I'm a licensed clinical social worker. Started in the field about a little over 30 years ago, and one of the things that I've seen is a trend in how many patients we deal with suicide ideality and attempts. We've certainly seen that more, especially during the COVID phase over the last couple of years. And I'm going to talk a little bit about that and how that's kind of changed what we do. One of the other trends I've noticed over the 30 years in this career is how we document suicide risk and our attempts to put safety plans in place. That's become extremely important. And it's gotten to the point now where I think most of us do that with almost every patient. 30 years ago, it was pretty clear, we did that with the patients we knew for sure were had some ideation, but now it seems like we do that pretty much for all patients. So I'm gonna go ahead and turn my video off and I will do the slideshow. I will turn the video back on at the end to take some questions. We have a lot of slides to get through, a short time to do it in. I didn't want to cut you short on slides, so you all have that in your handout. So I will be getting through these rather quickly and hopefully not too quick that you lose me, but by all means, reach out to me with any questions that you have after the webinar. So with that said, we will go ahead here and get started. First of all, before I start, I just want to make sure that it's clear that the presentation that I'm about to do is adapted from a number of sources. Mainly Dr. Bryan and Dr. Rudd with regards to some of the studies that have been done and the journals that have been written for patients in jails and prisons. There's one entitled Effective Crisis Response Planning versus Contracts for Safety on Suicide Risk with U.S. Army Soldiers. So I encourage you to reach it or to Google search these, try to read them if you can. And another slide here, Dr. Barbara Stanley and Dr. Greg Brown are really well known in the area of collaborative safety planning around suicide prevention. There's one piece written in particular called A Simple Emergency Room Intervention Can Help Cut Suicide Risk. And Dr. Stanley is a psychologist at Columbia University, and she is the lead author of a study entitled That's a Phenomenal Difference. It's actually regarding some work that she looked into that collaborative safety planning reduced the odds of suicide behavior by half. I also listed some resources online. Obviously, I think most of you are probably familiar with Zero Suicide, and then Suicide Safety Plan, and also simplepractice.com. So check those out when you can. In addition, Dr. Bryan, Dr. Mintz, and Dr. Clemens, again, both attempts at ideation were reduced for those with safety plans compared to a contract for safety. And we're actually going to talk a little bit about no harm contracts as well. I'm going to talk to you about some definitions with regards to what the CDC says we should be using for our language about these events and situations as well. What I want to make clear here, and I think what's clear in the research, is collaborative safety planning is an intervention that can be done at the very acute stage. So you'll see it a lot, for example, in jail settings or in the emergency rooms, but it can also be done at a very non-acute stage. So it can be done with someone who maybe isn't showing many signs of suicide ideation, but maybe there's a suicide ideation or attempt in the past. It could be many years ago. And in order to protect yourself, you want to make sure and cover that and document it well to avoid any kind of liability and to help our patients, obviously. So let's start with the definition of collaborative safety planning. It's an evidence-based, empirically supported intervention, and it is done between the clinician and the client The premise is that suicide risk fluctuates over time. There's times when the risk is higher versus times when it's lower. And it's important that we have a plan already in place that we discuss with our patients prior to them having that fluctuation be high. So this presentation is going to really kind of get to what collaborative safety planning is all about. How do you do it? It's going to seem basic. It's going to seem simple, but in the reality, I think a lot of us are looking for a smooth, kind of concrete way to do collaborative safety planning or suicide prevention with our patients. And this is something, obviously, evidence shows works well, and it works in all kinds of different settings. The objectives of the webinar today, and I've listed a number of them, and I really hope to reach these. We have a lot of slides, but understand the risk factors associated with suicide, describe how the pandemic has contributed to mental health concerns. We're going to talk about some myths. We're going to describe the components of collaborative safety planning, the what, why, and how of it. We're going to, hopefully you'll understand why you should implement reasons for living list with clients. Some people refer to this as a reasons for living inventory. We're going to look at identifying steps to addressing patient buy-in, which is a huge component to this, and also the steps to address patient follow-through. One of the things I want to point out right away is there's some research done on collaborative safety planning, and as we talk about it, you'll understand it a little better, but the research looks at how many patients in a prison setting were able to recall that that plan or find it within their cell area, I think 6 months later, and it was a staggering, like almost 80% that still had that was able to recall what their plan steps were. So this can really have a big impact on some of our patients. So in order to understand it, we're going to talk about some suicide rates. I'm going to go through these rather quickly, but they're stats. And what I'm going to do is I'm going to start with stats that are pre-COVID. So going back to 2019, which are the latest stats, obviously, that we have prior to COVID, we know that suicide risk was high. It's something that has been, if not a pandemic, near a pandemic, I think for us. We're certainly seeing that mental health and substance abuse is becoming more and more of a pandemic, especially through COVID. But I'm going to compare pre-COVID with COVID just so you can see some of the contrast. So in 2019, suicide was the second leading cause of death among individuals ages 10 to 34. The fourth leading cause between 35 and 44. This information comes from the National Institute on Mental Health. And there were nearly 2.5 times as many suicides in the United States as there were homicides in 2019. When we look at age-adjusted suicide rates, so these are suicide rates per 100,000 over time, you can see that the female population is on the bottom. They have a little bit lower risk, whereas males tend to have a higher risk. And then the middle line just shows total population, so it's going to be that average. This is clearly an indication, and it only goes back about 21 years, 22 years. But like I said, over my course of 30 years in the field, we've certainly seen this go from a rather low point or a lower point to becoming much more serious. So when we look at suicide rates by age group, what I want to make clear here is this is male versus female. It's not necessarily that 75-plus-year-olds are dying more by suicide. This is just looking at male versus female. So you can see once you get to that 75-plus-year-old range, that there's many more males that are dying by suicide than there are females. And you know, when you look down at the age of 10 to 14, it's pretty even. So it's important to look at this because we know that we're always concerned about risk factors, but if you can combine this in with a risk factor, it kind of helps you to maybe pay a little bit more attention to those age groups, especially that 10 to 14, understanding that females are almost just as much risk as males. Here it's suicide rates by race, and this is complementary of the CDC stats. We have an American Indian at the top. You can obviously see males are much more likely to die by suicide than females. And this is important. Obviously, we're all wanting to be culturally sensitive. You know, obviously this information is important to keep in mind, but it's not the, you know, there's many more risk factors, obviously, and we're going to talk about some of those as well. This slide I thought was very interesting, something I definitely wanted to show. And what you'll see here is that between the ages of 10 and 34, suicide, at least in 2017, according to this chart, was the second leading cause of death in that age group. You know, I've heard some ramblings that in the age 10 to 14 age group that might be number one. You know, stats are so strange that we need to wait, you know, a long time sometimes to get our stats right and back. But it'll be interesting to see how the pandemic affects these green areas on the chart. I hope that you'll look at this further. You can get this at the CDC website, and it's just under their stats for suicide prevention or suicide information. Another slide that I thought was quite interesting is suicide rates by state. Now, again, this is all pre-COVID. You can see that the West is very dark with more suicides occurring. All right, let's look at high-risk populations. So the definition is a high-risk population is characterized by having a high rate of multiple risk factors, and I put some stats here as well. One of the most staggering stats is suicide attempt survivors are 7 to 14 times more likely to die by suicide. This is an important stat because automatically when we know that somebody's had a suicide attempt in the past, they're at a higher risk. So we should be looking at doing collaborative safety planning in those situations. Now let's look at some stats post-COVID start. So there's going to be some dates in these. Symptoms of anxiety disorder and depressive disorder considerably increased in the US during the April to June period of 2020 compared to the same period in 2019. You can actually see by the chart, by the graph, it's about 31% increase, which is quite staggering. The prevalence of symptoms of anxiety disorder were 3 times more than those reported in the second quarter of 2019. And almost 4 times more in depressive disorders than what was reported in the second quarter of 2019. Suicide ideation was also elevated. Approximately twice as many respondents reported serious consideration of suicide in the 30 days. This is referring to post-COVID. Mental health conditions were also disproportionately affecting specific populations after COVID, such as young adults, Hispanic persons, Black persons. Essential workers were definitely part of that group. And during the 2020, the proportion of mental health related emergency department visits among adolescents aged 12 to 17 increased by 31%. So we're obviously not through the pandemic, but this is the toll that the pandemic is taking in another situation where we need to look at risk with our patients. Over 40% of people who die by suicide have seen a healthcare professional in the previous 30 days. This is alarming, and I think it's not only alarming, but it's also promising. It means that we've got an opportunity to intervene, to engage our patients. And we should certainly be focused on risk factors, and collaborative safety planning can be done so quickly that we can do that in a short amount of time. What I wanted to raise is there's some discouraged terms, and I'm still hearing the term suicide gesture. That's a term that CDC is discouraged the use of going forward. we can simply replace that with some suggested term replacement, and I'll let you guys review this and refer to it through your handouts. I don't think many of these are going to be surprising to you. These are risk factors associated with suicide. And there's a couple of risk factors actually on the next slide I want to just kind of really focus on. If we were in an audience, I'd probably ask you if you had any questions or you were surprised by any of these, but I think most of you probably understand these. So feeling hopeless is probably one of the largest risk factors. What we tend to see, especially in jail settings or prison settings or inpatient settings, residential care settings, is that anniversaries and important dates are something we should definitely be looking at. And then feeling alone or isolated from support systems has to be a big part, especially during COVID. And we should be asking our patients if they're feeling alone or isolated and how we want to deal with that. I'm not going to go through all the myths and facts. I think a lot of these, I believe that you'll get these, but they're also located in your handouts. What I want to make clear is there's a lot of myths out there that people are still believing, and we should be challenging those myths, not only with our patients, but our coworkers and our other staff that may not be doing the same kind of work we're doing. So it could be nurses or frontline staff that are involved in other ways. All right, let's get to collaborative safety planning. That's what we're here for, right? So first of all, a safety plan is the look or the focus on personal warning signs, self-management signs and strategies, how we're going to get social support and professional support. So why use a plan? We know that when we do, it results in a lower suicide rate. There's enough research to show that safety plans work as long as they're done correctly. And the most important is, I'll go back and talk about it, is some of our individuals, when they get to that point where they're feeling suicidal and they don't have a clear plan put in place, we could never expect them to think about a plan or put a plan in place. So we want to have this plan up front, long in advance, maybe even some practice on it prior to them getting to that point where their risk is high. All right, let's go another slide. We're going to talk about how to use a safety plan. Basically, the big key here is that it should be collaboratively done with our patients. In fact, some research, Dr. Stanley has done some of this too, has shown that patients who are more involved in writing their safety plan tend to follow it more, keep it longer, and have lower suicide rates. So we should, ideally be asking our patients to write the plan out so it's theirs, it feels like it's their property and they have some investment in it. So again, during times of crisis, most people find it hard to focus and make decisions effectively. So the safety plan being laid out in advance should help them a little more than having it introduced, obviously, after the fact. How to implement the safety plan with a patient. I think these are some questions that we could ask to get the safety plan started. What do you notice that's different when you're feeling distressed? How do others describe you when you're distressed? We should definitely query for situations, thoughts, images, sensations, mood, behavior. It's important to do that because some people don't understand that they're getting to the point of being distressed, and they need to know what those physical symptoms are so that they can start their safety planning. So ask patients what their warning signs are and triggers. That's the most important part. And I'm going to skip through, I'm going to kind of go through these slides pretty quick because I want to get to the actual plan itself, which I think will definitely make a little bit more sense for most of you. Again, implementing the safety plan is key. Having the patient buy in and having them write it is key. We won't always be able to do that. There's some patients that are just not going to want to write, but we might have to do that for them, but we should be asking them to do it. There should be a social support part to the plan. That's who the patient's going to reach out to if things aren't going well. We're going to identify those social supports, but not only identify them, but have them listed in the plan specifically. So if it's mom, what number are they going to reach mom at? On this slide, you'll see that we're even including a phone number for the National Lifeline in the plan. So make sure and think about professional supports as well. So this is an example of a safety plan. When they're feeling abandoned, they're going to use the plan. Or when they're thinking they have no control over their life, or whatever the situation is. So I'll ask the patient, what's going on typically before you feel suicidal, when you felt that way in the past, or before you get really depressed? And they'll talk about it. Maybe they've had an argument with their spouse. So they're going to use this plan when they have an argument with their spouse. So you're going to pick times prior, obviously prior to the suicide risk rising, to use the plan. So we should be looking at a few things. Number one, coping skills. What are you going to do when you realize that your risk is higher? Who are you going to call? Who are you going to reach out to? And there should be another component to this, which is reasons for living. And I'm going to get to that here in a second. It's actually suggested that this be written like on an index card. You can do it different ways. I'll show you another way in a little bit here. You can refer to that in your handout. A list of compelling reasons unique to the patient that motivates them. So don't just ask them, for example, what are your reasons for living? But ask them, what are your reasons for living? And when they give you one, say, can you explain that to me? Can you tell me more about that? What is it about your family that keeps you motivated to live? What kind of interactions do you have with your family? So it's important to focus on reasons for living that are really clear to the patient. Now, I will tell you, you'll meet with some patients that don't have reasons for living, and you're going to have to coach them a little bit and get them there. These are some example or information about why we use reasons for living. And I've got some slides too about how to implement reasons for living with a patient. I'm going to go ahead and let you guys read that through your handouts. I think everyone has kind of their own unique therapeutic way to reach patients in that regard. So for the sake of time, I'm going to get back to the card. So on the front of the card, we have those coping skills, who they're going to reach out to professionally and personally. And then on the back, we're going to put reasons for living. We've learned some things over time. I used to number these, but if you number them, sometimes patients will see it and they might think they only have 3, and that will cause them to get back into the kind of thinking of harming themselves. So we took the numbers off and we just list reasons for living. What we really want to do is ask the patient on a scale of 0 to 10, how likely are they to use it? Assess that before sending them back out of your office to use a safety plan. And then we're going to focus on patient buy-in. Patient buy-in is really, asking them, do you have your safety plan? Can you grab it for me? Do they know where it is? Do you remember what's on it? What have you used in your safety plan? So just motivating our patients about the use of it. Some questions to ask. Where will you keep the safety plan? How will you remember to use it? So these are important questions in determining, how their buy-in. Their buy-in will tell you what level of risk they're at as well. If they're able to answer these questions for the most part, and they got pretty sound answers, you're going to feel better about them being maybe not on a suicide watch, for example. So there's more patient follow-through. What I really want to get is to testaments real quick, patients in their own words. Basically, safety planning is very important for some patients. They need that. They found it as a way to kind of distract them back to thinking about the reasons that they have for living, for example. And it's been found to be very successful when it's used appropriately. This is a one-page sheet. I'll leave it, it's in your handout as well. You can refer to it on the front. It's those things too about when they use the plan, coping skills, and then on the back is reasons for living. The last thing, real quick, I want to talk about, and then we'll open it up to questions, is no harm contracts. Many of us are still using no harm contracts, and we shouldn't be. A no harm contract is something that's signed by the patient stating that they agree to not harm themselves up until a certain date. Usually the date is when they meet with the clinician again. What I want to say is there's no evidence that they work. In fact, there's research that show they could cause further risk. They provide a false sense of security, and there's really concern that it could open therapists up to legal liability. And that's the reason why collaborative safety planning is so important, because it goes well beyond just having an agreement that somebody's not going to harm themselves. So I hope that anyone that's using self or no harm contracts will reconsider and think about using collaborative safety planning. So with that, I'm going to get to questions. I'm going to turn my screen back on here, but I do want to say I got through all of that very quickly. I hope that you'll get a chance to read all the handouts, and certainly reach out to me. My email is up on your screen, and let me know what kind of questions that you might have, or if you're implementing things, where you're at with regards to success with your patients. So I'm just looking at some questions here that came in. So the question is, how do you do collaborative safety planning with involuntary clients? Well, that's a good question. Obviously, you need buy-in, and there's some tips in the slides that give you that. But I think most importantly is sometimes we need to coach our patients or clients a little bit. It's not that we're feeding them the information and writing it down as their safety plan. We're sort of gauging and checking with them about, will this work for you? So for example, let's say they can't come up with any reasons for living. They don't even want to be in your session. You might ask them, and give some examples. Say, well, what about your family? Do you got family involved? What about friends? What do you want to do in the future? If you can get them engaged into a discussion about that, it's one step further to being able to document your reasons for living. Let's see, another question that came in is, what if the client doesn't want to write out their collaborative safety planning? Definitely happens. I think what we need to do in those situations is write it for them. The most important thing is that we can leave them with a plan, their plan. As long as they're verbally involved in creating their plan, I think that's the most important part. I've certainly written many safety plans. We'd rather have our patients do it, but I've done it before. And it's been very successful in some cases. I've come back and maybe they've rewritten it, or we've asked questions like, what kinds of new things can we add to your coping skills for this week? All right. Looks like one last question here that I'm seeing on the screen is, how many reasons for living should a client be required to identify? Well, that's obviously going to be up to you as a clinician and your risk assessment, but you definitely want one or two. I think, for example, in situations where we have patients on suicide watch, reasons for living are something we need to document before we might consider allowing them off of watch. So we might feed them a reason for living on day one. So for example, we'll talk to them about what their future goals are. And then on day two, when we come back, say, hey, remember yesterday we talked about your future goals. Have you given any more thought to that? So reasons for living should be documented specifically for each patient. So if a patient tells you their reasons for living is their 2-year-old son, David, then you should document 2-year-old son, David. All right, it looks like with that, we're out of questions, unless anyone has any more. I got you about 2 minutes beyond with a lot of slides. So thank you for letting me do this today. I hope you guys got something out of this. Collaborative safety planning is so important. Reach out to me with any questions or comments, and I appreciate your time today. Thank you.